Hi, my name is Amber Brewster. Today we look beyond basic nutrition to examine how a single routine micronutrient intervention supports newborn survival. I will begin with a case study illustrating the devastating reality of vitamin K deficiency bleeding, then review the biological mechanics of this vital nutrient for blood clotting, and reveal why this one simple preventative medical intervention remains one of modern medicine's most critical public health successes. A 4-week-old full-term male infant arrived at the emergency department. The 32-year-old mother explained that she noticed blood in her baby's stool after he vomited. The physician noted the baby was uncircumcised and asked the mother to provide details of the birth. The mother explained that the birth was an uncomplicated vaginal delivery at home, her second full-term pregnancy. She noted that her infant was exclusively breastfed and had normal bowel movements daily. The physician suspected the infant was unvaccinated and did not receive intramuscular vitamin K due to at-home birth circumstances. He asked her, and his assumptions were correct. Home births frequently correlate with refusal of standard prophylactic vitamin K and newborn circumcision. Initial examination indicated nothing unusual or noteworthy during the evaluation. Although during intravenous line placement, there was noticeable rhythmic movement of the right lower extremity. Based on the clinical presentation of blood in stool, lethargy, and vomiting, the doctor suspected a lack of prophylactic vitamin K at birth, causing internal bleeding. He notes that the infant may be experiencing a focal motor seizure upon IV line placement and orders labs and a CT scan. Laboratory findings included microscopic hematuria paired with severe blood clotting failure. A urine dipstick test showed the presence of blood in the urine, reflexing to a urine microscopic exam to confirm and count the number of red blood cells, denoting 182 red blood cells per high power field. Pediatric findings of blood in urine is likely a direct result of the patient's inability to clot properly, leading to spontaneous bleeding in the urinary tract or other vital internal organs. The PT-INR and PTT coagulation studies were all abnormally prolonged, indicating the patient is in a state of severe coagulopathy, a life-threatening medical emergency where blood is unable to clot, leading to uncontrolled spontaneous hemorrhage. The CT scan revealed multiple intracranial hemorrhages and brain swelling. The arrow in A and B, bilateral subdural hemorrhages, crescent-shaped collections of blood visible in the space between the dura mater and the arachnoid membrane. The arrow in C, subarachnoid hemorrhage, displays blood flowing in the cerebrospinal fluid spaces surrounding the brain. The clinical significance of the arrowhead in B shows bleeding deep within the brain's gray matter. And the arrowhead in C, subpial hemorrhage, indicates the pia mater membrane is lifting away from the surface of the brain due to bleeding. Diffuse cerebral edema occurs secondary to the pressure from multiple brain hemorrhages. Brain swelling causes a loss of gray and white matter distinction in CT imaging. Initial lab and imaging findings supported a pediatric admission to the intensive care unit as the infant began experiencing ongoing seizures. The 4-week-old exclusively breastfed full-term male infant developed severe vitamin K dependent coagulopathy. The patient was admitted to the pediatric intensive care unit for urgent stabilization and management of life-threatening internal bleeding secondary to vitamin K deficiency bleeding. Vitamin K deficiency bleeding directly disrupts the body's chemical chain reaction for clotting, measured by PT-INR and PTT laboratory tests. Vitamin K deficiency leads to an inability to gamma-carboxylate clotting factors 2, 7, 9, and 10. Note the red circle indicating vitamin K dependent factors. The prothrombin time, PT, and its standardized ratio, the International Normalized Ratio, INR, evaluate the extrinsic and common coagulation pathways. When vitamin K is depleted, factor 7 levels drop first. The PT-INR is abnormally prolonged very early in the disease process. The partial thromboplastin time evaluates factor 9 in the intrinsic pathway and factors 10 and 2 in the common coagulation pathway. Due to multiple inactive factors, the PTT test will also become abnormally prolonged. The critical inability to form clots causes potential life-threatening internal bleeding and intracranial hemorrhages that may result in permanent brain damage or death. Late onset vitamin K deficiency bleeding is most common in breastfed infants that have not received vitamin K prophylaxis at birth. Vitamin K deficiency bleeding was confirmed by the patient's prothrombin time being over 4 times the normal upper limit. Coagulation levels successfully normalized after vitamin K intramuscular injection was administered. The liver synthesizes essential blood clotting factors, inactive precursor proteins, in red, bottom center. To activate them, the liver requires vitamin K hydroquinone as a cofactor to drive an essential post-translational modification process called gamma carboxylation. Vitamin K drives gamma carboxylation by converting glutamic acid GLU residues into gamma carboxyglutamic acid GLA residues. Gamma glutamyl carboxylase enzyme transforms inactive proteins into functional clotting factors capable of binding to calcium and cell membranes to drive the clotting cascade toward clot formation. Active vitamin K hydroquinone is oxidized into inactive vitamin K2,3 epoxide, ensuring continuous production of clotting factors via the vitamin K cycle. Vitamin K epoxide reductase is the enzyme responsible for recycling inactive vitamin K to its reduced active hydroquinone form. If the patient is vitamin K deficient, the liver still makes the proteins, but they remain inactive and useless. Consequently, vitamin K deficiency leads to a significant risk of uncontrolled bleeding and/or hemorrhage. To prevent vitamin K deficiency bleeding, the recommended treatment is a 0.5 to 1 milligram single dose intramuscular injection of prophylactic vitamin K. Intramuscular injection is preferred over oral vitamin K prophylaxis as the absorption is independent of intestinal and biliary function. It provides near complete protection and is the medical standard for newborns. Vitamin K is progressively released into systemic circulation, rapidly raising blood levels to safely initiate the liver's blood clotting system. The intramuscular injection provides a depot that is slowly utilized over the next 8 to 12 weeks. The infant's developing gut microbiome will slowly begin to produce its own vitamin K, and the introduction of solid foods will provide external dietary sources to maintain healthy levels naturally. The 4 main molecular and developmental determinants of functional vitamin K insufficiency in newborns are poor placental vitamin K transfer, developmental immaturity of the liver and vitamin K cycle, a sterile neonatal gut microbiome, and low concentration of vitamin K in human breast milk. Vitamin K is a fat-soluble molecule, and the maternal placenta transport is low. Newborn hepatic uptake of chylomicron remnants containing vitamin K is severely underdeveloped, leading to prolonged circulation, preventing rapid internalization of vitamin K to activate clotting factors. Newborns also have lower activity levels of the enzymes supporting the vitamin K cycle, which leads to secretion of inactive, undercarboxylated clotting factors. Human breast milk is a poor source of vitamin K and does not provide enough vitamin K to support basic physiological requirements. The newborn lacks endogenous synthesis of vitamin K by intestinal bacteria, depriving the newborn of essential vitamin K. Classical vitamin K deficiency bleeding is primarily driven by developmental and nutritional deficits. Genetic variations can significantly exacerbate functional vitamin K insufficiency. Although rare, vitamin K-dependent coagulation factor deficiency impairs the body's ability to activate clotting factors. Reduced gamma carboxylation efficiency prevents post-translational carboxylation of clotting factors, rendering them inactive even with adequate dietary vitamin K. Genetic mutations that predispose infants to late-onset vitamin K deficiency bleeding include malabsorptive syndromes, underscoring the importance of the universal standard of care, intramuscular vitamin K shot at birth to bypass intestinal absorption and override enzymatic inefficiency. A single-dose intramuscular injection of prophylactic vitamin K ensures every baby is protected. Vitamin K deficiency bleeding and intracranial hemorrhage is a life-threatening emergency. Brain bleeds have a fatal risk of about 20%, leaving 40% with permanent long-term neurologic disability. This condition requires immediate medical intervention, close monitoring, and long-term follow-up to rule out underlying causes. While the frequency of follow-up visits depends on bleeding severity and hematocrit stability, the prognosis is great for uncomplicated cases as coagulation factors will normalize over time with immediate and adequate vitamin K prophylaxis. Since 1961, the American Academy of Pediatrics has supported vitamin K intramuscular prophylaxis. It is essential for preventing life-threatening intracranial bleeding. Opposition to newborn intramuscular vitamin K injections is primarily driven by sensationalist media undermining the confidence in standard medical treatment for preventing vitamin K deficiency bleeding. For parental concerns regarding injection pain and bruising, potential exposure to preservatives, and a desire for a natural, intervention-free birth, the benefits far outweigh the most dangerous consequence of vitamin K deficiency bleeding that can lead to permanent neurological damage or death. For parents that strongly resist the intramuscular injection, oral vitamin K is less effective and requires multiple doses, but does not eliminate the risk of vitamin K deficiency bleeding as reliably as the injection. A single shot of vitamin K prophylaxis is a routine neonatal procedure that safeguards infants for up to 6 months until their gut microbiome develops and solid food feeding provides sufficient production of vitamin K to support health. The newborn vitamin K shot is a profound public health success because it nearly eliminated a devastating and often fatal condition in infants. Vitamin K deficiency bleeding is a preventable, life-threatening condition in newborns, with intramuscular prophylaxis serving as the gold standard for prevention. To learn more about the critical importance of newborn vitamin K prophylaxis and the clinical evidence behind these guidelines, please explore the foundational studies and case reports listed in the references.